Hello, and welcome to the MCG Training Guide. In this video, we will guide you through the process of understanding and interpreting your MCG report. The report itself contains several pages which we will go over in detail. The main page, which contains a summary of the patient's information as well as their primary test results. The secondary page, which contains suggested comorbidities or standalone diagnosis based on the MCG's analysis, and the remaining pages which contain the full ECG tracing chart that was used for each test's analysis. As you can see here, the main page is broken up into the following sections. 1. The patient name and MCG identification number. 2. The session ID for the test and the patient's demographic information as inputted earlier in their creation. 3. A summary of the MCG's test results, including MCG test IDs and relevant dates, the technician's quality assessment for each test's tracings, the results for both local and global ischemia detection, and an assigned severity score for each test. Please note that the results for local and global ischemia, as well as the MCG severity score, have been strongly correlated with the presence of disease of functional myocardial ischemia caused by stages of obstructive coronary artery disease, ranging from as little as 30% coronary artery lumens encroachment to critical stenosis defined as 50% left main and or 75% large epicardial coronary arteries, such as LAD, RCA, or other larger branches. These have all been confirmed with FFR, also known as functional fractional reserve. A positive result for the presence of local ischemia indicates regional or patchy ischemia, possibly resulting from single or double vessel disease. A positive result for the presence of global ischemia indicates large areas of ischemia, possibly due to major proximal vessel coronary artery disease. This includes left main or combined proximal LAD or RCA critical stenosis. Please bear in mind that local or global ischemia caused by anatomic obstructive coronary artery disease can be exacerbated by metabolically induced oxidative stress. Therefore, hyperglycemia, hyperlipidemia, endothelial dysfunctions, and/or diffused microvascular diseases can lead to higher severity scores. Therefore, it may be extremely beneficial to identify and treat these disorders and treat their impact on the patient's overall severity score. Furthermore, other comorbidities such as anemia, various cases of hypercoagulation, hypoxia due to COPD, radiation/chemotherapy exposure, hypoxemia, high altitude sickness, decompression sickness, congenital heart anomalies, heavy metal poisoning, and etc. can also exacerbate the symptoms and severity of coronary ischemia. Therefore, caution should be taken before sending patients to premature coronary interventions or needless hospitalizations. If the patient is asymptomatic but with high MCG severity scores and myocardial ischemia, the patients and doctor should discuss their options. But the first line of defense should be a conservative but aggressive course of medical treatment, and one should avoid a diagnostic coronary angiogram and interventional procedures unless it's absolutely necessary. This is a cautious approach that has been substantiated by the COURAGE trial. Again, the second page contains suggested comorbidities or standalone diagnosis based on the MCG's analysis, which are presented in the following two matrices. The pathological conditions matrix represents secondary disease categories, including arrhythmias and prior myocardial damage from cardiac events. The physiopathological conditions matrix represents findings which are closely associated with abnormal cardiac function, but which may have other explanations than cardiac pathology. Presence of a specific pathological or physiopathological condition on multiple tests serves as a good indicator that this condition may be present in your patient. Patients presented with the following secondary or tertiary findings, such as the presence of myocardial damage, ventricular arrhythmia/fibrillation, global or local asynchrony, myocardial remodeling or ventricular hypertrophy, lowered ejection fractions, or combinations of these conditions should be referred to a qualified cardiologist or electrophysiologist whom readily accepts the MCG's report in an expeditious manner. Periodic follow-up with the patient using an MCG personal monitoring unit to oversee progress on a regular basis is also recommended, as well as changing the patient's treatment course as necessary in consultation with your patient and the cardiologist or electrophysiologist that they are seeing. However, we must make this clear. These are recommendations for further investigation and confirmation. This should not be considered as a definitive diagnosis that can be taken at face value. The remainder of the report will be the full ECG tracing chart that was used for each test's analysis. The test ID appears at the bottom of each page and can be matched to the test IDs for summary and suggestion pages. Please note that these are for tracing quality determination only and not for reading as a traditional time domain ECG strip, which is why a voltage over time scale is not provided. That about covers what you'll see when you start reading a report. I hope this video was helpful, and if you'd like to learn more about how to use the MCG device or access our web app, please refer to our other training videos and have a wonderful day.